Welcome, and thank you for joining us today for our International Myeloma Workshop Daily Update. I'm Mary Jerome, Director of Medical Communication and Education at the Multiple Myeloma Research Foundation, and I'm here in Boston for day 3 of the IMW. Today, I'm joined by Dr. Shaji Kumar from the Mayo Clinic in Rochester, Minnesota, and Dr. Noopur Raje from Massachusetts General Hospital in Boston. Shaji and Noopur will be reviewing what's new with respect to patients with relapsed and refractory myeloma, as well as recent developments in bone disease detection and management. So let's get started. So Shaji, I wanted to ask you about something that's on the mind of many of our patients, our relapsed refractory patients who are receiving Darzalex or will soon be receiving Darzalex. We've talked a lot at this meeting about the subcutaneous formulation of Darzalex, and everyone wants to know when is this going to be available because it's going to be such a matter of convenience for patients. Is there any more information available about how the subcutaneous version works compared to the current intravenous formulation?
Yeah, you bring up a good point. I mean, Darzalex, we all know, is quite effective drug and increasingly part of every different combination we use for newly diagnosed as well as relapsed disease. One of the biggest problem with Darzalex or daratumumab is the time it takes for the drug to be infused, and often for the first infusion especially, they have to be in the clinic for pretty much the whole day. Even though we have made some advances in terms of giving it in a much shorter fashion using the 90-minute infusions that can be done from the 4th dose onwards, it is still a burden for the patients to have to come every week, be in the clinic for 3 hours, 4 hours. So there has been understandably a lot of interest around the subcutaneous version. So what they have done is to mix up the daratumumab with an enzyme called hyaluronidase, which essentially what it does is separate the connective tissue that is underneath the skin to kind of make some false space into which the drug can then be injected. And they're using a very concentrated formulation that can, again, a very small volume that can be infused under the skin with the help of this particular enzyme. It's not necessarily a new concept per se. It's been done with other drugs, but for a anti-CD38 monoclonal antibody, this is the first one we have that hopefully will hit the market soon. Now, in terms of the time frame, I don't have exact dates, but I think the popular belief is sometime early next year, early to middle of next year, it should be available. And that I think will be a major change for patients with newly diagnosed or relapsed disease who needs to get the drug.
So you're talking with maybe a 5-minute subcutaneous infusion, right, versus a many-hour IV infusion, right, which is going to be such an advance for patients. So is there any reason why a patient who has received IV Darzalex can't receive the subcutaneous version?
There's no reason, unless somebody is having persistent reactions with the IV formulation. That may be something that we don't have much data for because none of the clinical trials included those patients in there. So I think everybody should be able to get the subcutaneous daratumumab. Obviously, if somebody develops any reaction to those injections, they may have to go back to the IV form if that's something unique to the subcutaneous.
So let's talk a little bit about those reactions. Noopur, in your clinic, what have you seen with reactions as far as the Darzalex IV infusion?
So the daratumumab IV infusions, I know we talk a lot about the reactions here, but honestly, you see the reactions with probably your first dose and your second dose. And over the years, I think most of us have gotten so comfortable using these drugs. And, the pre-medications that we use with drugs like daratumumab have really made a big difference. And we're using leukotriene inhibitors now routinely. This is montelukast that you use as a pre-medication, and this has allowed us to mitigate for the allergic reactions. So most of the reaction, the fever, the rashes are almost not seen anymore. We do see a little bit of a tightening in the throat when patients get their first infusion, a little bit of a cough, maybe a little bit of shortness of breath, but that's quite well managed with some of the supportive care strategies we have. We use steroids, we use these leukotriene inhibitors, you use anti-allergy medicines like Allegra and Claritin, and with that it's made a tremendous amount of difference. And as Shaji has pointed out already, in the old days, we used to use that 8-hour infusion for the first infusion. We are getting a whole lot better now with our supportive care strategies, and we are going to 90-minute infusions. What Shaji has just told us about the subcutaneous version is going to be a game changer. And I think what we haven't really sort of addressed right now is it works just as well as the IV. And it's just that the pharmacokinetics of that is a little bit different, where the daratumumab levels rise a little slower because you're giving it subcutaneously, so you don't see that acute toxicity. But Shaji is absolutely right. I think you have to wait out a little bit, and it is potentially possible that the subcutaneous version might cause a little bit of delay. Not these allergic reactions, but other toxicities. And the other important piece we've noted now, based on the phase 3 data, is there's no difference in efficacy, which is really reassuring.
That is reassuring. Is that the same type of experience you had in your clinic as well, Shaji?
Absolutely. I think we have gotten all so familiar with using daratumumab, even more so than us. The nursing staff who actually give the infusions are so much more comfortable now.
Good.
And one other aspect I just wanted to say is there's also the option of giving that first dose divided over 2 days. So some of the patients, if they're getting infusion in a clinic which maybe only be open for till 5 or 6, it may not be an option for them to give it all in one day, and they can split it over 2 days for the first infusion.
So, Noopur, the combination therapy with Darzalex is used for many patients in the relapsed refractory disease setting with much success, but those patients will eventually relapse, even using this treatment. So what can you tell us about the new CD38 antibody that's sort of coming on the scene now, isatuximab? It's similar to Darzalex. People in our audience want to know about whether they can potentially go on isatuximab if their Darzalex fails, and if it will be effective.
So the data we have right now, so isatuximab, the new CD38 monoclonal antibody, essentially targets the same antigen as does daratumumab. The studies which have been done with isatuximab, one of the eligibility criteria, the criteria to go on to that trial would exclude people who've been exposed to daratumumab. So to be honest, we don't have data on if you progress with daratumumab, can isatuximab be useful there? For all practical purposes, ISA targets the same antigen. We are going to see very similar efficacy. There's a little bit of data at this meeting about reinfusions, and the data is sort of all over the place in terms of whether or not you can get a response. And it is to do with if you still have the CD38 antigen on your tumor, there is a possibility of getting some of that response back, and it's going to be really quite individualized, and it will have to be the patient and the caregiver making that kind of a decision.
I think I did hear someone say yesterday that with some of the other really exciting therapies that are being developed now in clinical trials, such as the BiTEs and the ADCs, that going on to ISA after you fail Darzalex wouldn't necessarily be the first option that people would take.
No, I agree. I think without any data, it's hard to say if it's going to be of any additional benefit. If you look at the data with isatuximab alone or in combination with pomalidomide, it's very similar to what we have seen with daratumumab with alone or in combination. So I think so far we don't have any information to say it acts in any way different than what daratumumab does. In myeloma, we always recycle therapies, so something that's been used, we may use it again. Most of the time, we try to use it maybe a cycle or a line of therapy later, maybe the next time when they relapse. And it's quite possible that the anti-CD38 monoclonal antibodies may be reused again. There are phase 3 trials or planned phase 3 trials that will look at the question of, is it good to retreat somebody with daratumumab, which I suspect can be applied to other monoclonal antibodies as well. But there are some drugs that are in development that supposedly has a more affinity to that CD38 compared to what daratumumab and isatuximab has. Once they come out into clinical trials, maybe we will see the target being reused.
So these are like the next generation of CD38 monoclonals. Oh, interesting. Okay. So Shaji, this morning you were chairing a session on previously treated myeloma, and you presented the long-awaited Bellini trial data. which is talking about the use of venetoclax. Many people in our audience are curious about the status of venetoclax because it's on a partial clinical hold now because deaths were reported on the trial. So what can you tell our patients about the study and the current status of venetoclax development, and is it still even a candidate for patients with myeloma?
That's a very important question, and I think we are all still quite excited about that molecule. Clearly, there's biology that backs the use of a BCL2 inhibitor in myeloma. We have seen incredible activity with the drug in the context of patients, especially ones with translocation 11-14. When it was used as a single agent, we saw about 40% of the patients respond. You combine it with dexamethasone, about 65% of the patients respond. And when you combine that with bortezomib, nearly all the patients have some degree of response in the early trials. And that's what led to the development of the Bellini trial, which essentially looked at the venetoclax in combination with bortezomib dexamethasone against bortezomib dexamethasone. Now, the trial results clearly shows us that when you add venetoclax to bortezomib dexamethasone, you increase the overall response rate, but more importantly, it actually increases the depth of response, a much higher complete response rate compared to just using bortezomib dex alone. And even when you look at the MRD negativity rate, it's almost 13% of the patients would be MRD negative compared to just 1% of the patients without venetoclax. What really took us by surprise was the increased numbers of deaths that we observed in the patients getting the venetoclax combination. So because of that finding, we did go back in and dig deeply into the data to see if it will provide us some clues as to what happened. There were a few interesting points that emerged. The first one was that most of the deaths were related to infection, especially infection that was happening in the context of disease progression. We also noticed that the patients who did not benefit were the ones who actually had high-risk cytogenetics or patients who were low expressors of the BCL2. So it almost seems like a perfect storm, so to speak, where you have a high-risk disease that does not respond to treatment, but you're being treated with a combination that can potentially decrease your immune system and that can set you up for increased risk of infection. So when you look at just those groups with the 11-14 translocation or the high BCL2 expression, those patients did not appear to have an increased risk of death, but certainly appeared to have a similar benefit in terms of the progression-free survival. So I think the way we are looking at it right now is the 11-14 patient group seems to be quite promising. There's a phase 3 trial looking at venetoclax dex versus pomalidomide dexamethasone. The patients who have high BCL2 expression is again a candidate for clinical trials. What we need to do is to have a reliable test that can identify the patients with high BCL2 expression. And then there's going to be about a third of the patients or so, maybe 40% of the patients who appear to have really no benefit. Then the question in those patients is, should we even be thinking about it? If we are thinking about using venetoclax, should we be thinking about some other combination other than the bortezomib combination? So I think it provides us a clear path as to moving forward, and I'm fairly confident that it will be available for use in those patients, but it also gives us a unique insight into the disease biology that we need to continue to study.
So when will that trial results be, or the data be announced?
So that's still enrolling. So my guess is it probably will finish enrollment, hopefully, by middle of next year, in which case maybe early 2021 is what
I
we
had
would
heard
say.
that the timeline was going to be pushed back significantly, which might not be, it's unfortunate for patients that the drug might benefit, but we need to make sure it's safe. So.
That is absolutely correct.
I think this is a perfect example actually of a niche-specific drug in myeloma. It's not one size fits all. And I think learning from the Bellini data, it's taught us, as Shaji's pointed out so nicely, is there is a subgroup of patients who will benefit, and specifically the ones which are the BCL2 overexpressors or the 11-14 translocated. And as long as we have the good tests to identify those, we have patients who don't even need the addition of the third drug like the bortezomib or the carfilzomib added on to this backbone. And again, some drug development needs to occur in niche patient populations. And your trial has actually taught us that this time.
I think it reinforces we are not dealing with one disease, multiple diseases. So.
Correct.
Very true, very true. So let's talk about any other key takeaways in treating patients with relapsed or refractory myeloma, Shaji, in your session or in any other data that's been presented at this meeting? Anything, specifically focusing on treatments that are currently available for patients that has had some new and interesting information that's come out at this IMW meeting?
Yeah, there were a few interesting abstracts presented in that session. Dr. Matthias presented the data looking at carfilzomib dexamethasone in patients who are frail. I think that was reassuring. Obviously, that combination is a effective regimen. Again, once weekly carfilzomib. Again, talking about the patient convenience part of things, that is important. And she was able to show that even the more frail patients were able to tolerate those medications with the appropriate dose adjustments and still able to get good benefit from using that drug combination. Dr. Dimopoulos presented some data, again looking at patients who were treated with the pomalidomide, bortezomib, dexamethasone on the Optimism trial, again highlighting the impact of using that PI plus IMiD combination in a group of patients who are mostly refractory to or had previously been exposed to lenalidomide. We have a variety of different choices right now for those patients whom we often see in the clinical practice. And I think the data was reassuring and more longer-term follow-up. There was also the information from the ICARIA trial that looked at isatuximab that we just talked about. And that looked at the combination of isatuximab, pomalidomide, and dexamethasone. And they looked specifically at the patients with high-risk cytogenetics. And they were able to show that those patients also benefited with the addition of that monoclonal antibody to the pomalidomide dexamethasone combination. Finally, there was some cumulative analysis of two different trials that were combined, looking at the combination of carfilzomib, pomalidomide, and dexamethasone from Dr. Ante Jakubowiak. And that he was able to show that that regimen was effective in terms of overall response rate. Almost 2/3 of the patients responded. There was a median progression-free survival, which was about 12 months for that particular regimen. So I think we are continuing to add more and more combinations that we feel are safe to use, effective to use in patients with relapsed disease.
Yeah. And Noopur, there was also some talks on what we would consider to be more novel targets and drugs that are not yet available to patients, such as the MCL1 inhibitors and melflufen. Can you comment on those?
Sure. So, obviously the good news in myeloma is we keep having more and more drugs, and that's great for all our patients. And MCL1 inhibitors are being tested in clinical trials. They're still very early in clinical development, but they dovetail very nicely with venetoclax. So venetoclax, for example, targets BCL2, and there is a specific subset of multiple myeloma which is BCL2 dependent. But in general, the learning and the teaching has always been that the majority of myeloma is MCL1 dependent. So a drug like these MCL1 inhibitors, and the one which is furthest in development is AMG 176, an Amgen MCL1 inhibitor, should have efficacy. Again, it's a first-in-human trial and still going through dose escalation. And we'll have to wait and see as to what that data looks like. So clearly a new class of drugs and something which we think is going to be more applicable to the vast majority of multiple myeloma patients. Along the same lines, we've had a very recent approval of another drug called selinexor, a completely different class of drug. It's an nuclear export protein inhibitor, so really not an IMiD, not a proteasome inhibitor, works extremely differently, and it has been approved in the setting wherein patients have been exposed to whatever's currently available, so proteasome inhibitors, IMiDs, as well as all monoclonal antibodies, the so-called penta-refractory patients with multiple myeloma. Typically, you don't have a lot of options at that point in time. I will say, though, that we have to learn a lot more about selinexor. It's fantastic that we have this drug approval, but now it really, the onus is upon us for us to figure out how best to use it so that patients can actually tolerate this drug, because there is some issues around tolerability. But if it's given at sort of reduced doses with weekly schedules, those of us who've used it I do think we're going to be able to hit that sweet spot there and get people to be able to tolerate it, and it certainly does work in this patient population. So there's a lot of interesting things. You know, BCMA has always been an interesting target. There was a monoclonal antibody session earlier on today, and there's a new GSK antibody which has been fast-tracked for accelerated approval as well. So we are looking forward to seeing some of the DREAM study data, which should be presented hopefully at ASH, and hopefully we'll get another new monoclonal antibody approved in the setting of myeloma.
Anything to add to this topic?
No, I
Shaji?
think it's exciting times as always.
exciting times.
We find newer drugs, newer targets.
So, Noopur, you chaired a session this morning on myeloma bone disease, which is always something that our patients, talk a great deal about. They have many common questions, such as, are bones still at risk of deteriorating if the patient is in remission, or if they have a very low level of M protein? And, if they have an X-ray and it's normal, does that mean that they need to be on a bisphosphonate or another bone strengthening drug? What did we learn today from the session that you chaired about any new information coming out about bone health? Any key points that our patients should know in that area?
So, a lot of interesting things on bone disease, and I'll kind of summarize some of it. But the question that you asked earlier is really relevant. Are you at a risk of developing bone disease? And there was a really nice presentation from the Icelandic kind of large data set where they have lots and lots of patients, about 14,000 patients. And what that data set has very nicely shown us, something we've always known. We know that if a patient with multiple myeloma presents with a fracture at the time of diagnosis, they're at a higher risk of presenting with more fractures. We also know that if you have a fracture and our patients, it is associated with a significant amount of pain and morbidity, and we should try and avoid that as much as possible. And this was confirmed again in this very large data set. What it also showed was there is a risk of developing fractures again, and those fractures can happen at a very delayed time frame. And I think the presenter who presented the data today said as late as 10 years as well. I do believe that a patient with multiple myeloma is always at a risk for ongoing bone disease. Obviously, when the disease is in remission, that risk does get mitigated. But when the disease comes back again, you're still at that same risk of developing more bony problems. The other thing I think is really important to recognize is, the treatment for myeloma, we include a lot of steroids. We are trying to use more and more steroid-free drugs now, but steroids in itself can cause osteopenia, can cause osteoporosis. So treatment-related bone problems can also occur, and therefore I do think people should be on a bone-targeted agent. Certainly can back off on the frequency, because you do not want to give too much of a drug either, because we've seen some of the problems associated with that, such as the osteonecrosis of the jaw, stress fractures. So too much of anything is never a good thing. And we have done studies wherein we've given these drugs less frequently. I think the other very important take-home message from this morning's session was, how do you follow patients, or how do you pick up bone disease? And X-rays used to be done, and we all have done skeletal surveys in all our patients. But now, with both Shaji, me being part of the NCCN also, we've incorporated some of the newer imaging modalities, and that's become part of the definition also of how we define active symptomatic myeloma. So stopping at X-rays is not good enough. And I think most of us would say you should get a myeloma CT survey, which gives you a lot more information, and you get it accurate information in 90% of people. There was nice data which was presented with whole body MRIs and PET CT scans, and the data suggested that MRIs tend to be more sensitive in picking up more disease. But PET CT scans, because of the fact that they are functional, you can actually follow PET CT scans in terms of looking at response in patients. This might change over time, because we are going to do functional dynamic MRIs as well. We are not quite there, but the bottom line for patients is don't stop at an X-ray. You need to do better than an X-ray. It could be a CAT scan, it could be a PET CT scan or an MRI, and the risk of bone disease doesn't go away, and you need to be on bone-targeted agents. And along those lines, I think the one other thing I will mention for patients, because this is critically important, it's not just the bone-targeted agent. Make sure you're calcium supplemented, and make sure you're taking your vitamin D as well, because that's really critically important.
Are there new imaging methods that are in development right now that you think will really help with this problem of making sure that all of the bone issues are detected?
You bring up a great point, and there was a very interesting presentation today wherein we are using certain things for imaging. Like in this case, it was a CXCR4 marker, and CXCR4 is a protein which is overexpressed on multiple myeloma cells, and when you include that marker into the PET imaging, the chances of picking up more bone disease is there. We at Mass General have done methionine scans, and methionine scans are supposed to be even more sensitive than your FDG PET. That's still very early data. It's not quite ready for prime time, but stay tuned. You know, we are going to get more information, and we are going to get better at detecting this.
Right, this is such a big, it's a very large concern for patients. Anything to add, Shaji?
No, I think Noopur summarized it nicely. I think it's a probably the most important part in terms of the supportive care management, because almost a third of these patients have severe bone disease right away from the beginning, and they continue to happen during the course of the disease. I think we just need to continue to work on optimizing what is needed to be done for prevention of bone, skeletal events. I think increasingly we are becoming aware maybe we don't need to give as much as what we are giving right now. And I know Noopur's done studies looking at biomarkers to try and see if we can try and to give less and get the same benefit.
So, I mean, this has been a great discussion, and I thank you so much for being here. I mean, we've gone through quite a number of things in our discussion today. We've talked about relapsed and refractory myeloma, availability, about subcutaneous dara and when that might be available. We've talked about isatuximab. We've talked about venetoclax. We've talked about new therapies that might be coming along, and talked a lot about bone disease and imaging. So I think that that's a lot of really interesting information for patients, and useful and actionable as well. So I thank you both for being here. And hey, we've got one more morning to go, and we have some really interesting information that will be coming out tomorrow. So, and it's been a great meeting so far. I'm sure you guys agree, right?
Thank you.
Yeah, it's great.
Been fun, and
been really good.
It's always good to host in Boston as well.
Yes, right. It makes it life easier for you, right, Noopur?
Sure.
Great. Okay, so on behalf of the MMRF, I'd like to thank Dr. Kumar and Dr. Raje for joining me today. I'd also like to thank everyone for watching this update. And finally, I'd like to thank AbbVie, Amgen, Bristol Myers Squibb, Celgene, Cure Magazine, Genentech, GlaxoSmithKline, Janssen, Karyopharm, Novartis, Sanofi, and Takeda Oncology for sponsoring these daily updates. If you have additional questions about what you've heard today on this webinar, please call the nurses at our MMRF Patient Navigation Center at 888-841-MMRF, which is 6673. So this concludes our series of daily updates from this year's International Myeloma Workshop. A recording of each update will be available on our website.